so many of these clinical situations. Yeah, there are so many hidden problems that when you start to uncover them, and true, most people survive anyway, but.
Do you think the problem is mandatory for you in school?
Well, I think, you know, in my practice it is, because when people come to me, they want to know why they got the clot. That's part of them knowing why they got the clot, especially spontaneous thrombosis in a non-varicose vein. Varicose veins are a little different.
Gentlemen.
Post iliofemoral thrombectomy, are the patient to continue an anticoagulant or not? And if it is to continue an anticoagulant, for how long?
Well, they must. They must remain on anticoagulation, because the purpose of anticoagulation is to reduce the risk of recurrence. So patients are at high risk of recurrence early on, and that risk diminishes over time. One of the problems with venous thrombectomy years ago was that there was completely inadequate post-op anticoagulation, so patients rethrombosed frequently, and that led to some of the poor outcomes that have been alluded to with operative intervention. So yes, we would therapeutically anticoagulate our patients post-operatively and continue for an extended period of time. By definition, if a patient has an iliofemoral DVT, we will anticoagulate for a minimum of a year, a minimum, and then talk to the patient after that to see if they ought to continue. And when one understands that the risk of bleeding from anticoagulation is high early on, and if patients don't bleed within the first 3 months of anticoagulation, the risk of bleeding from anticoagulation diminishes over time. So that always factors into our decision making.
Jonathan?
The duration of anticoagulation is mumbo jumbo and magic, isn't it? I was really impressed. Let me finish the question. I was really impressed with a paper recently that randomized people at 3 months to continuing anticoagulation or to have anticoagulation based on the results of a duplex scan. And if the duplex scan's normal, then you stop the anticoagulation. Isn't that introducing just a teeny weeny touch of science into anticoagulation?
Well, actually, there's a couple facts. If you look at every randomized trial, and Jonathan, correct me if I'm wrong or point out one exception to this rule. Every randomized trial that has looked at shorter versus longer duration of anticoagulation after deep venous thrombosis has shown significant benefit to longer duration compared to shorter, whatever those durations were, 6 weeks versus 6 months, 3 months versus indefinite anticoagulation. There's always a trade-off with a little higher risk of a bleed versus a significantly higher risk of thrombosis. Those are patient populations. Now, what Jonathan is talking about, and what I do, is when you have a single patient in front of you, that's all of us, what is your recommendation going to be for that single patient? And after 1 year, see, this is the follow-up question, what do you do after 1 year? After 1 year, if the duplex is normal, if there's residual thrombus in there, as defined by Paolo Prandoni, we'll continue. If the duplex is normal, we will consider stopping. If we stop, then we get a D-dimer 1 month after discontinuing. If the D-dimer is high, I will recommend that the patient go back on anticoagulation. If it's negative, then I think you've just identified the patient who has the lowest risk of rethrombosis.
Okay, I'm going to stop the panel. The gentleman.
A 25-year-old young woman with iliac vein compression syndrome had an acute iliac DVT, recanalized post-catheter directed thrombolysis, and we put a stent. Would you consider prophylactic thrombophylaxis, and for how long?
How big was the stent?
I don't know about the size or the level.
The important thing is to make sure the stent is large. It needs to be